I am Dr. Elnemr, a professor of surgical oncology. My lectures will cover the topic of liver surgery. In the first lecture, I will present the liver anatomy and common congenital anomalies. The liver is the largest gland in the body, about 1.5 kilograms. It's soft, easily friable, highly vascular, surrounded by fibrous sheaths known as Gleason's capsule. The liver is located in the right hypochondrium part of the epigastrium, part of the left hypochondrium. It is a wedge-shaped organ, has 5 surfaces: the anterior surface, superior surface, inferior surface, posterior surface, and right lateral surface. The right lateral surface forms the base of the wedge. These surfaces are separated by ill-defined borders, except for the inferior border, which is sharp and separate the anterior surface and right lateral surface from the inferior surface. The liver is covered completely by peritoneum except for the area in the posterior surface named as bare area. The liver is composed of 2 loops, a large right loop and smaller left loop. They are separated on the anterior and superior surface by the attachment of the falciform ligament, and on the inferior surface they are separated by the fissure for ligamentum teres. On the posterior surface they are separated by the fissure for ligamentum venosum. The liver is related anteriorly to the anterior abdominal wall and diaphragm, which separate it from the pleura and the base of the lung on each side. The superior surface is also related to the diaphragm, which separate it from the pleura and the base of the lung on each side. The middle portion separate the liver also from the pericardium and the heart. The right lateral surface is related to the right copula of the diaphragm, which separate the liver from the right pleura and lung, and the ribs from number 6 to number 11. The inferior surface is directed downward, backward, and slightly to the left. It is related to the body of the stomach, the lesser omentum, the pylorus and first part of the duodenum, the right colic flexure, and posteriorly the right kidney and right suprarenal gland. When the liver is hardened in situ, the inferior surface is marked by impressions of the viscera related to it. The inferior surface of the left loop is related to the gastric impression made by the body of the stomach. Just to the right side of this impression there is a rounded elevation called tuber omental related to the anterior surface of the lesser omentum. The inferior surface of the liver is covered by peritoneum except the gallbladder fossa, the porta hepatis, and fissure for ligamentum teres. Now the quadrate loop. The quadrate loop is a rectangular shaped part of the right loop, bounded anteriorly by the inferior border of the liver, posteriorly the porta hepatis, on the right side the gallbladder fossa, on the left side the fissure for ligamentum teres. The quadrate loop is related anterior to the transverse colon, the middle portion related to the pylorus and first part of the duodenum. The posterior part is related to the lesser omentum. Just to the right side of the gallbladder fossa there is an duodenal impression which is related to the upper portion of the second part of duodenum, and just to the right side of this duodenal impression there is a large smooth area called renal impression related to the anterior surface of the right kidney, and posteriorly in this area the suprarenal impression, which in close relation to the groove for the inferior vena cava and the Bair area. Anteriorly in this surface there is an impression related to the right hepatic flexure. Now the posterior surface of the liver, which is formed by three parts: the Bair area of the liver, the groove for the inferior vena cava, and the quadrate loop. The quadrate loop covered by peritoneum, which separated from the diaphragm and the descending thoracic aorta. The quadrate loop has a process called papillary process, and the quadrate process merge with the rest of the right loop. The quadrate loop is bounded inferiorly by the porta hepatis, superiorly by the ligamentum venosum and left hepatic vein when they curve to join the inferior vena cava. To the left side, the fissure for ligamentum venosum, the right side, the groove for inferior vena cava. The groove for inferior vena cava lies between the Bair area and the quadrate loop. It is a deep groove, and this groove pierced by the hepatic veins to join the inferior vena cava. Sometimes the hepatic substance cover or make bridge that cover the inferior vena cava. The name is pons hepatica or pons hepatis. This is a more clear view of the posterior view. We can see the three parts of the posterior surface: the Bair area, the groove for inferior vena cava, and the quadrate loop. We can see also the ligamentum teres and then ligamentum venosum, starting from the left portal vein, ascending the fissure for ligamentum venosum, curving around the posterior part of the quadrate loop to join the inferior vena cava. We can see also how the triangular ligaments forms. In the left side, this is the anterior layer of the left triangular ligament, and this is the posterior layer of the left triangular ligament. They fuse together or join together to form the left triangular ligament. On the right side, we can see the upper layer of the right coronary ligament. This comes from the reflection from the undersurface of the diaphragm. That's why it's called the hepatophrenic ligament. And then the lower part, or the lower layer, which comes from the reflection in front of the right kidney. That's why it's called sometimes the hepatorenal ligament. The two layers, the upper and lower layer, or coronary, upper coronary and lower coronary, fuse together to form the right triangular ligament. Now, what are the structures holding the liver in place and responsible for its stability? The most important factor holding the liver in place is the hepatic veins. The three hepatic veins anchor the liver to the inferior vena cava. Number two, the vascular remnant, the round ligament, and ligamentum venosum. Number three, the peritoneal folds. The most important peritoneal fold holding the liver is the falciform ligament, which attach the liver to the undersurface of the diaphragm and the anterior abdominal wall. Then the left triangular ligament, the right triangular ligament, the hepatoduodenal ligament here, and then the gastrohepatic ligament. Less importantly, the supporting viscera and the tone of abdominal muscle. Here we see the ligamentum venosum connecting the left portal pedicle or left portal vein to the inferior vena cava, and the ligamentum teres from the left portal pedicle, left portal vein, and attach to the umbilicus. The ligamentum teres is the obliterated left para-umbilical vein. The ligamentum venosum is the obliterated ductus venosus. This is a gastrohepatic ligament connecting the undersurface of the liver to the lesser curvature of the stomach, and the hepatoduodenal ligament connecting the hilum of the liver to the pylorus and the first part of the duodenum. This ligament contains the portal vein, hepatic artery, and bile duct. We can see also here the hepatorenal ligament. The structures within the hepatoduodenal ligament and porta hepatis are the portal vein posteriorly, anterior to the right the bile duct, anterior to the left the hepatic artery. The liver has dual blood supply from the hepatic artery and portal vein. The hepatic artery is responsible for 20% of the flow and 50% of the oxygen supply. The celiac trunk give rise to left gastric artery, splenic artery, and common hepatic artery. The common hepatic artery, after giving the gastroduodenal artery and right gastric artery and the supraduodenal artery, continues as hepatic artery proper, which run in the hepatoduodenal ligament to reach the hilum of the liver and divide into two terminal branches, left hepatic artery and right hepatic artery. The right hepatic artery, before entering the liver, give small branch to the gallbladder called cystic artery. Only 55 to 65 of population has normal anatomy, and this is some examples of the abnormal anatomy. Here we can see the left hepatic artery and right hepatic artery arise independently from the celiac trunk. In this example, we can see the main hepatic artery arising from the superior mesenteric artery. In this example, we can see the right hepatic artery only arise from the superior mesenteric artery. Here in this example, you can see the left hepatic artery arising from the left gastric artery. In this example, we can see an extra right hepatic artery arising from the superior mesenteric artery. In this example, we can see extra left hepatic artery arising from the left gastric artery. The second source of the blood going to the liver is the portal vein, which carries 75% of hepatic blood flow and 50% of the oxygen supply. The portal vein is valveless, about 1 to 3 cm in diameter, 5 to 8 cm in length. The pressure in it is 4 to 5 mm mercury. The portal vein formed behind the neck of the pancreas by the union of splenic vein and superior mesenteric vein. It receives the left and right gastric vein and cystic vein from the gallbladder, and then enter into the hepatic hilum. The blood flow in the portal vein has stream-like phenomena or has a laminar flow. In other words, the blood coming from the spleen and stomach, pancreas, and left side of the colon go to the left side of the portal vein and mainly directed to the left hepatic loop, and other from the small intestine and right colon is going to the right loop. There are three main hepatic veins: right hepatic vein, middle hepatic vein, left hepatic vein. They are drained into the inferior vena cava. Sometimes the left hepatic vein and the middle hepatic vein join together to form a common trunk. There are also short hepatic veins from the caudate lobe open directly into the inferior vena cava. The functional unit of the liver is the hepatic lobule and the hepatic acinus. The liver has a wide range of functions which account for its complex structure. The first function is the bile synthesis and secretion, both bile pigment and bile acids. Number two, excretion of bilirubin. Three, protein synthesis, especially albumin and the clotting factor like prothrombin and fibrinogen. Number four, gluconeogenesis, in which the lipids and amino acids are converted into glucose. Number five, storage of triglycerides, glycogen, and some vitamins. Number six, deamination of amino acid to produce urea, which is excreted by the kidney. Number seven, conjugation and the chemical breakdown of toxins by the enzymes of endocellular reticulum to other metabolites. Surgical anatomy of the liver. The liver is divided into left surgical loop and right surgical loop, or left hemiliver and right hemiliver, by imaginary line named Cantor's line or cholecystocapal plane. This line passes from the middle of the gallbladder fossa to the middle of the inferior vena cava. This line corresponds to the middle hepatic vein. Another two vertical planes corresponding to the left hepatic vein and right hepatic vein divide each loop into two sectors. The left hepatic vein divide the left lobe into lateral sector and medial sector. The right hepatic vein divide the right lobe into anterior sector and posterior sector. Now we have four sectors: the lateral sector, medial sector, anterior sector, and posterior sector. Another horizontal plane at the level of the portal vein bifurcation within the liver divide each sector into two segments, upper and lower, upper and lower. So we have upper lateral segment, lower lateral segment, upper medial segment, lower medial segment, upper anterior segment, lower anterior segment, upper posterior segment, lower posterior segment. So if you put numbers, so segment 2, segment 3, segment 4, A and B, segment 5, segment 6, 7, 8. In a clockwise manner, it will be easy. So segment 1. Segment 1 is the caudate loop, and this is an autonomous segment or loop lying between the portal vein and the inferior vena cava. It is an autonomous loop, receive its arterial supply from both right and left hepatic artery, portal supply from both left portal vein and right portal vein, and drain directly into the inferior vena cava. Also, the biliary drainage through the left and right hepatic duct. At the porta hepatis, the hepatic artery divided into long left hepatic artery and short right hepatic artery after giving the cystic artery. The left hepatic artery branches into lateral branch and medial branch. The lateral branch supplies segment 2 and 3. The medial branch supplies segment for A and B. The right hepatic artery divides into anterior branch or division and posterior division. The anterior division supplies segment 5 inferiorly and segment 8 superiorly. The posterior branch supply segment 7 and segment 6. The same for the portal vein. At the portal hepatis, it divides into a long left portal vein and short right portal vein. The left portal vein has two portions. The transverse portion is long, and then the vertical portion. The vertical portion divides into branches to segment 2, 3, and 2 branches for segment A and B. The right portal vein divides into an anterior division and posterior division. The anterior division divides to supply segment 8 and segment 5. The posterior division divides to supply segment 6 and segment 7. The terminology of hepatic resections. If we remove surgically the left surgical lobe, it will be left hepatectomy. If we remove the right surgical lobe, it will be right hepatectomy. If we remove the right surgical lobe plus segment 4, it will be extended right hepatectomy. If we remove the segment 2 and 3, it will be left lobectomy. If we remove segment 4 and segment 5 and 8, the name will be mesohepatectomy or central hepatectomy. However, one sector can be removed, like sector 6 and 7 or 2 and 3. It's called sectorectomy, or even one segment, like segment 6 to segment 6 segmentectomy, or S6 segmentectomy, S3 segmentectomy, etc. The non-anatomical or non-formal resection includes the wedge resection or partial hepatectomy, the resectional debridement in the case of blunt trauma to the liver, and hemangioma or cyst inoculation. The common congenital anomalies of the liver are hepatotosis and renal loop. The first anomaly is hepatotosis, or wandering or floating liver, in which the complete dislocation of the liver may occur, or the alternative appearance of the liver on the right and left side. It may be congenital or acquired. The underlying mechanism may be lax or absent suspensory ligaments or stretching of the inferior vena cava. The causes are repeated pregnancy due to lax abdominal wall, tapping of ascites, trauma, and overstraining and tight lacing. The clinical presentation is usually non-specific and may be abdominal pain, nausea, vomiting, anorexia, distension, loss of liver, dullness on percussion. Sometimes the colon may be interposed between the liver and diaphragm, leading to what's called Chilaiditi sign. Here we can see the colonic gas between the upper surface of the liver and the diaphragm. In this contrast study, you can see the liver also between the chest wall and the liver. Ultrasound images and CT scan may be needed, and the condition may be only discovered at exploratory laparotomy. The treatment of hepatotosis is hepatopexy by fixation of the falciform ligament to the right diaphragm. fixation of the ligamentum teres with the distal part of the falciform ligament to the anterior abdominal wall. If the mesentery to the stomach or transverse colon is elongated, they can be plicated to prevent volvulus. And the technique of hepatobiopsy can be done by open surgery or laparoscopic surgery. The second anomaly is Riedel loop. It is a normal anatomical variant, occurs in 3.3 to 14.5% of the population. It is a tongue-like projection from the inferior surface of the right lobe and may be quite large, sometimes extending into the right iliac fossa. The etiology has been debated but may be attributed to edema from cholecystitis and appendicitis or hepatic tumors, or constrictions from the tight corset. Its prevalence increased with the age, as 60% occur in the people between 45 and 65 years. The variants of Riedel's loop, this is a Riedel loop from the prolongation from the right loop. Sometimes Riedel-like loop may be protruded from the left loop, and sometimes anomalous loop passing through the diaphragm to the pleural cavity. In this coronal CT, we can see the liver reaching the right iliac fossa and near the iliac crest. Also in the axial section, the liver reaching to lower slices. Here is the iliac bone. This condition is very important and must be considered in the differential diagnosis of mucocele of the gallbladder or tumor of the right lobe or enlarged right kidney. Thank you.